Multifocal lenses can give some patients good distance, computer and near vision, often with significantly reduced dependence on glasses. But they do that by making some optical trade-off. And in the wrong patient, it is possible to have technically successful surgery, read all the way down the chart and still be quite unsatisfied with the quality of your vision. So the question is not, are multifocal lenses good? The real question is, are the benefits of multifocal lenses worth the compromise for your particular eyes and your particular lifestyle? In this video, I'll explain what multifocal lenses can realistically achieve, what problems they can cause, and most importantly, who should and should not consider having them. I'm Mr. Mohammed Ahmed. I'm a consultant ophthalmologist specializing in corneal, cataract and refractive surgery. I will say that this video is for general education purposes only. Whether a particular lens is suitable for your eyes or not can only be determined after a detailed consultation and examination, as well as consultation with your own surgeon. This video is not sponsored and I'm not recommending a particular lens brand. During cataract surgery or refractive lens exchange, the natural lens in the eye is removed and replaced with an artificial lens. If that artificial lens is a monofocal lens, that means it will provide excellent vision at one particular focal point. For example, the vision may be set for distance, which means excellent vision for activities like driving, watching TV, but it does mean that glasses will be required for reading. A multifocal lens, on the other hand, is designed to provide useful distance at various different focal points. Modern versions are called trifocal or full range lenses because they are designed to provide useful vision at distance, intermediate, so computer work and dashboard in a car, as well as near vision, so activities like reading a menu or a book. But it is important to understand that this is not the same as restoring natural vision of a healthy 20-year-old. When we are young, the natural lens can physically change its shape, and that allows us to shift the focus from distance to close-up tasks. An artificial multifocal lens cannot do that. Instead, its optical design creates more than one useful focus at the same time. Your visual system then has to use the image that's the most useful for the particular task that you perform. This distinction is quite important to understand because while multifocal lenses can increase the range of vision, they do not produce every quality of a natural young. For a carefully selected patient, multifocal lenses can actually provide very useful range of vision. So for distance, it can mean they are able to perform activities like watching TV, going for a walk, and if all the other requirements are met, being able to drive without glasses. At intermediate distance, it may help with activities like working on a computer, looking at a dashboard in the car, shopping or seeing across the room. At near, it can allow you to look at your phone, look at the label in the supermarket, being able to read a normal sized textbook. So the major attraction is not necessarily that each of those vision is optically perfect. It's that for most day-to-day activities that the individual is able to move between these activities without repeatedly having to take their glasses on and off. This can be genuinely liberating for the right patient. However, no responsible surgeon will say that the patient will never need glasses again. Even with the good results, some patients may still choose to perform certain tasks with the help of glasses. So that can include activities like reading very small print, performing a very detailed task, reading in a dim light, or occasionally someone may choose to wear glasses for best distance vision in the dark. The reading distance also matters, so a lens may provide the ability to read a menu or a book at a particular arm's length distance, but not necessarily very close up. Another lens may provide very good vision for computer work, but maybe slightly weaker for near vision. So near vision is not a single distance, and glasses free is not an all or nothing outcome. The aim is to reduce dependence on glasses, but not to guarantee that glasses will never be useful. I would say that this is the most important part of the video. There is no free lunch in optics. A monofocal lens concentrates most of its useful light at one particular focal point. A multifocal lens, on the other hand, distributes the light between various different focal points. This allows a greater range of vision, but the light is no longer being used in a simple way as it is in a monofocal lens. The potential result is a reduction in certain aspects of visual quality, particularly contrast sensitivity. Contrast sensitivity is different from being able to read black letters on a white chart. It is your ability to be able to detect subtle differences between an object and its background. So examples would be driving at dusk, seeing in dim light, being able to recognize someone in a poorly lit room, or seeing detail in rain, fog or glare. Having said that, many patients with multifocal lenses are very happy with the quality of their vision. and are very satisfied. But compared with monofocal lenses, the multifocal lenses are much more likely to produce optical side effects, especially around lights. These can include glare, halos, starbursts, rings around headlight, or a general reduction in how crisp night vision is. A halo can look like a ring around headlights or a street lamp. A starburst may make a point of light appear to have multiple rays coming out of it. Now, some patients notice these effects but are not particularly bothered by them. Others may find them distracting, particularly when driving at night, and a small number may find very difficult to adapt these. This is why two patients can have very similar measurements but describe their experience very differently. So one patient could say, I can see glare and halos but they don't bother me at all and my vision is very good, and someone else could say that I'm very distressed by these glare and halos even though I know I can read all the way down the chart but my vision doesn't feel very natural. Both of these experiences can be genuine. Now, you may hear the term neuroadaptation. What that means is over time the brain may become better at taking useful information and paying less attention to distracting phenomena like glare and halos. Many patients do find that the halos that they experience immediately after surgery do become less noticeable over time in the months after the surgery. But neuroadaptation should never be presented as a guarantee. It's not responsible to tell every unhappy patient that your brain will definitely adapt, just wait. Some patients do adapt very well. Some continue to notice these side effects, but they find that the freedom that they get from glasses is worth it. And a smaller group continues to find these symptoms quite intrusive. So the decision should really be based on whether you would be willing to accept the possibilities of these side effects, not the guarantee that they will disappear. A good candidate is not simply someone who can afford a premium lens. The patient, the eye, and their expectations all have to fit together. A multifocal lens may be appropriate for someone who places a high value on reducing their dependence on glasses for distance, intermediate, and near tasks. They understand that the greater range of vision comes with possible compromises in contrast sensitivity and nighttime visual quality. They're not expecting perfect vision at every single distance in all light conditions, and they understand that the glasses may still be useful for certain tasks. And critically, they have eyes that are likely to provide a good quality image for the multifocal lens to work well. Generally, a good candidate will have a healthy ocular surface, a regular cornea, a healthy macula and retina, a normal optic nerve, two eyes that work together well, and measurements that are repeatable and accurate. Any significant astigmatism also needs to be considered properly. In some patients, a toric multifocal lens may reduce both the amount of presbyopia as well as the astigmatism. But the astigmatism must be regular and the measurements must be reliable. The best candidate, therefore, is not someone who demands a multifocal lens. It is the patient whose priorities, eyes, and tolerance of compromises aligns well with what the lens is likely to deliver. There is not always a list of absolute yes or no rules. The severity of any eye condition matters, and different lens designs have different tolerances. But there are several situations where I would be cautious. The first is significant dry eyes, blepharitis, or an unstable tear film. The tear film is the first optical surface of the eye. If the tear film is irregular, it can affect both the quality of measurements as well as the quality of the vision after the surgery. A patient may assume that all their symptoms are being caused by the lens when part of those symptoms may actually be coming from the tear film. Now, dry eyes does not mean that multifocal lenses can definitely not be used. It's important to diagnose it and treat it before a final lens decision is made. If, for example, measurements change every time they are repeated, then that's a warning sign. I would be quite cautious of using a multifocal lens in someone who has an irregular cornea. That can be from keratoconus, corneal scarring, irregular astigmatism, corneal dystrophies, or higher order aberration. A multifocal lens introduces a complex optical system in the eye. If the cornea is already contributing significant optical distortion, then combining the two may actually lead to a poor quality of vision. Some patients who have had LASIK or PRK in the past can still have a presbyopia correcting lens, but the assessment and lens calculation is usually more complex, and the quality of the cornea also needs to be considered very carefully. Previous laser surgery is not automatically a prohibition. It just means that the decision just requires more caution, and a more forgiving lens may sometimes be more appropriate. The macula is a central part of the retina responsible for fine detailed vision. Conditions like age-related macular degeneration, epiretinal membrane, diabetic macular changes, or other retinal diseases can actually affect quality of the vision. Now, the evidence is not strong enough at the moment to confidently say that every macular disease is a contraindication. However, if the retina is already limiting the contrast of fine central vision, I would be cautious of using a lens that may reduce the contrast further. This is one reason why a macular OCT can be quite useful before considering the lens procedure. So a patient can read quite well on a standard chart, but the OCT reveals some subtle macular changes which change our lens recommendation. Similar caution may be needed in patients who have glaucoma, optic nerve disease, or advanced visual field loss. Now, early and stable disease is different from advanced or progressive disease, but if contrast sensitivity and visual field are already compromised, a multifocal lens may not provide the best balance of visual quality and range. Multifocal lenses generally work best when both eyes contribute useful vision and work effectively as a pair. If one eye has significant amblyopia, otherwise known as a lazy eye, or if there is squint suppression or another binocular visual problem, then the expected benefit of a multifocal lens may be reduced. The weaker eye may not provide enough high quality information, and the stronger eye may be doing most of the visual work. Now, that does not mean that every small difference between the two eyes rules out a multifocal lens, but in the presence of significant amblyopia or binocular dysfunction, we tend to be very cautious when using premium lenses. Lifestyle is just as important as eye examination. If someone drives quite frequently at night or flies professionally, frequently performs activities in low light and low contrast conditions, then they may place much greater value over cleanest possible optical quality. Now, that does not automatically rule out a multifocal lens, but the possibility of glare and halos becomes much more important when considering the lens. So the key question is not just do you drive at night, because most people do, but the more useful question is how important is the best possible nighttime visual quality to your work and lifestyle. Sometimes the eyes are technically suitable, but the expectations are not. A multifocal lens may be the wrong choice for someone who says, I want perfect vision at every single distance, I want perfect vision at night, I do not want to wear glasses under any circumstances, I will not tolerate glare and halos, or I expect my vision to be how it was in my 20s. Those are understandable desires, but unfortunately, based on the current technology that we have, these are not results that we can reliably deliver. I would also be cautious when someone automatically assumes that the newest, most expensive and widest range lens is automatically the best lens. A multifocal lens is not an upgrade in the same way as getting a new TV or a new computer. It's actually a different optical strategy. It does give something, so a greater range of vision, reduced dependence on glasses, but it may take something away in terms of contrast, optical simplicity, and tolerance of small imperfections. The right lens is usually whose trade-offs fit the patient best. Multifocal lenses can be much less forgiving of small imperfections than monofocal lenses, for example. A small residual prescription, which would barely trouble someone with monofocal lenses, may be quite bothersome for someone who has multifocal lenses. The same may apply to a small amount of residual astigmatism, dry eyes, slight lens decentration, a little bit of posterior capsular opacification, or subtle retinal disease. These phenomena may have a much greater impact on the quality of perceived vision. This is why accurate measurements and careful surgery matter, but this is also why perfection cannot be guaranteed. Modern biometry is extremely advanced, but it is still a prediction of how the eyes will naturally heal and where their lens will naturally sit inside the eye. Occasionally, the eye can heal with a small residual prescription, despite the measurements from the optical biometry being perfect, as well as the surgery being technically absolutely fine. Before choosing a multifocal lens, the patient should understand what the plan would be if that did happen. Depending on the outcome, the options could be simply allowing more time for healing, treating the ocular surface, using glasses for certain tasks, laser vision correction, inserting in an additional lens in the eye, or very rarely removing the multifocal lens and exchanging it for a simpler lens. Now, selecting a multifocal lens should involve much more than just choosing a lens from a brochure. First, the surgeon needs to understand what the patient is actually trying to achieve. Do they want to read a phone without glasses? Are they working on a computer? Are they playing golf? Do they drive frequently at night? Do they read for several hours a day? The phrase, I want to be glasses free, is not detailed enough. We need to understand the distances and tasks that matter most. The eye examination can then include assessment of the ocular surface, the cornea and the regularity or irregularity of it, the back of the eye including the macula and the retina, the optic nerve, the macular scans, the optical biometry, and assessment of the eye to see how well the two eyes work together and whether there's any weakness. The measurements should generally agree with each other. If, however, there is discrepancy between the measurements, sometimes it can indicate that the eyes are slightly dry, and therefore that needs to be treated first before undertaking repeat measurements. If the macular scans reveal any abnormality, then the strategy for the lens may need to change. If there is significant astigmatism, that simply can't be ignored. In refractive cataract surgery, one of the most important decisions that a surgeon makes may simply be choosing a different lens to what initially attracted the patient. Are all multifocal lenses the same? The answer is no. There are various different optical designs, including bifocal, trifocal, or full range of vision lenses. Some use diffractive optics, others combine different optical properties. Different designs may place different emphasis on near vision, intermediate vision, light distribution, or reducing particular optical phenomenon. There are also lenses called extended depth of focus lenses, or EDOF lenses. These lenses are slightly different from multifocal or trifocal lenses. Broadly speaking, an extended depth of focus lens is designed to extend the range of focus from distance towards intermediate vision. It may provide a more continuous range depending on the lens design and may cause fewer glare and halos compared to a multifocal lens. However, the trade-off is weaker near vision with slightly greater need for glasses for close-up work compared to a multifocal lens. The boundaries, however, between different lens types is becoming more blurred because newer lenses are starting to combine different optical properties. That's why I'd prefer not to make universal statements like this particular multifocal lens is the best. A lens can perform very well, but the question remains, best for whom? Lens names and technologies will continue to evolve. The fundamental balance between range of vision, optical quality, and unwanted side effects will remain. It may be helpful to compare broad strategies. It offers the greatest opportunity for independence from glasses, but it generally carries the highest risk of glare, halos, and reduced contrast. An EDOF lens, on the other hand, prioritizes distance and intermediate vision and can give some variable near vision. It may offer a somewhat more forgiving optical profile, but it still can cause some glare and halos in some individuals, and reading glasses may be needed for particularly small print. Monovision uses a different strategy. So one eye is set for distance and the other eye, or usually the non-dominant eye, is set for intermediate or near work. It does not divide the light like a multifocal lens does, because usually a monofocal lens is used in this case. However, it does ask the brain to combine images from eyes which are set at two different focal points, and that can sometimes cause difficulties with depth perception or binocular visual quality in some people. A standard monofocal lens provides the simplest optical strategy. It can provide excellent quality of vision at a selected focus, but it does mean that glasses will be required for tasks at other distances. None of these options is universally superior. Each prioritizes a different balance. If someone is unhappy after multifocal lens surgery, then the concern should be taken seriously. It's important to identify what could be causing the problem rather than simply assuming that the patient needs more time. The surgeon may need to assess the residual prescription, the quality of the tear film, the health of the cornea as well as the macula at the back of the eye, as well as the capsule behind the lens. A small residual prescription or the opacification of the capsule or dry eyes can sometimes explain why the patient may be experiencing these difficulties, and treating those can sometimes help. However, sometimes the patient just needs to spend more time with the lens and allow the brain to adapt. Sometimes, however, a further procedure can be required. If the capsule, for example, is opacified, then a YAG laser procedure can be performed to open up the capsule and improve the quality of the vision. It does need to be considered very carefully though, because once the capsule is opened, the option of lens placement does become more complicated. Lens exchange is a possible option, but it is much more complex than the original operation, and it has to be considered very carefully. It should not be presented as an easy option or a guaranteed route to recovery. Now, fortunately, most patients do not need to have their lenses exchanged after they've had the procedure, but the possibility of persistent optical imperfections should really be discussed before the surgery and not after the problems already occurred. If you are considering multifocal lens surgery, I would ask yourself 3 questions. First, how important is reducing dependence on glasses? Is it simply a preference, or is it one of your highest priorities? Second, what optical compromises am I willing to accept? If I can read my phone without glasses, will I be comfortable with glare and halo, especially in the dark? Or will even a mild reduction in my nighttime visual quality significantly affect my work or lifestyle? And thirdly, are my eyes actually suitable? Not just in terms of the state of the lens or the cataract, but also in terms of the tear film, the cornea, astigmatism, the retina, the macula, and the optic nerve at the back of the eye, as well as binocular vision. A good decision requires satisfactory answers to all three questions. Wanting the benefit is not enough by itself. Multifocal lenses are not inherently good or bad. For the right patient with the right eyes and the right expectations, they can provide a significant range of vision with a meaningful reduction in dependence on glass. For the wrong patient, the same lens can cause glare and halos and reduce contrast and satisfaction with the outcome, even when the operation has gone very well. So the aim should not be to choose the lens with the longest list of features. It should be to choose an optical compromise that best matches your eyes and your expectations. The best lens is not necessarily the newest lens or the most expensive lens or the one with the widest range. It's the lens that's most likely to give you the kind of vision you will actually value. In the next video, I'll answer another important question: will I need glasses after cataract surgery or refractive lens exchange? Because the answer does not depend just on the type of your lens, but also depends on your eyes, your visual targets and tasks you want to perform. If you are considering cataract surgery or lens replacement surgery, you may find my previous videos helpful. They explain how artificial lenses are selected and also discuss risk, recovery and expectations after surgery. And you can let me know in the comments, what would you prefer after surgery? Being able to read without glasses or having the highest quality nighttime vision? Thank you.